Hi, everyone. I will just get started with our kind of introductory slides. So thank you so much for joining us today for another one of our webinar series. Just a reminder for our webinar instructions. So if you can mute your microphone right now, that would be great, just so that while Dr. Nguyen is talking, she can be clearly heard. And also, if you are able to, would love to see all of your lovely faces, so please enable your video by clicking on the icon below. So if you have any questions during the talk, please feel free to use our chat function to post those questions throughout the lecture, and then I'll kind of run through those questions at the very end. But I think Dr. Nguyen will also have some questions for us as the audience as well to participate. If you would like to change your username, you're able to follow these instructions here. And then just as a reminder, you can also claim CME accreditation. Just remember to complete the following after each webinar, so the evaluation form as well as the post-test evaluation. And those links should be emailed to you after the conference. And then just a reminder also, if you could fill out the online evaluation form, we'd greatly appreciate that. And that should also be sent to your email address after the conference today as well. So for all the fellows, since we're not able to have a meal together, just as a reminder, the NCSCG would like to offer fellows who attend the webinars a meal up to the value of $30 to be eaten during the webinar session. And so here are the instructions to follow to be able to get reimbursed. The main thing will just be emailing Danny afterwards. And then for grant support, we gratefully acknowledge the following companies for their educational grants in support of this educational activity. And so getting to our agenda, so the topic tonight, so we're going to be talking about complex cases and hot topics and motility disorders with Dr. Linda Nguyen from Stanford. Apologize for the misspelling here. And then just a reminder for our upcoming events. So on May 11th, we'll have the updates and approach to diagnosis and management of pancreatic lesions with Dr. Walter Park. And then on June 22nd, we'll have vascular diseases of the liver with Dr. Chanda Ho from CPMC. And we'd just like to thank the NCSCG Education and Training Committee for all of their hard work and dedication in putting together this webinar series, as well as our committee chairs listed here. And also a reminder to save the dates for the 18th annual NCSCG GI Symposium that will be at the last weekend of June. And thank you so much. So just as a quick, or as an introduction for our speaker today, Dr. Linda Nguyen. So she is a clinical associate professor, director of the Neurogastroenterology and Motility program, and the clinic chief in the division of gastroenterology and hepatology at Stanford University. Dr. Nguyen completed her medical school training at UCLA School of Medicine, and then her GI fellowship training at California Pacific Medical Center in San Francisco, California. Her clinical and research interests include functional and motility disorders of the gut, with an emphasis on gastroparesis and functional dyspepsia, and a special interest in visceral hypersensitivity and autonomic dysfunction. She was a member of the NIH-NIDDK Gastroparesis Clinical Research Consortium from 2007 to 2016, and her current research focuses on the role of neuromodulation on inflammation, physiology, and symptoms. She's also very passionate about quality of life, professional development, and physician well-being. Dr. Nguyen has served on and chaired numerous DW abstract review committees and 2 ad hoc committees for the National Academy of Science. And she currently serves as a member of the American Neurogastroenterology and Motility Society Council. So thank you so much again for taking the time this evening, Dr. Nguyen, to share and speak with us. We're very excited and looking forward to your talk.
Great. Thanks, Connie, for the kind introduction. And let me share my screen here. And actually, since hot off the press, since I sent that bio, I have been recently promoted to clinical professor. And I've also stepped down as director of neuro GI and motility. So Layla Nashatian has taken over that role. So part of my wellness is stepping down and shedding different responsibilities. So happy to talk about that someday if you'd like. What I would love, since normally if we did this in person, I would get a chance to interact and engage with you guys. So as with if you guys can just in the chat box, tell me who you are, where you're at, and if you're a fellow, like what year you are. That just helps me know who you are. And if you can, please turn on your video. I don't care if you've got your cat, your dog, your kids, you're in PJs, you're disheveled. I don't mind that as long as you're wearing clothes. If you're wearing clothes, please turn on your camera. I would greatly appreciate that. And so my goal for today is really to develop like a physiologic-based framework for approaching patients with complex GI disorders. So hopefully when you leave here, at the end of the session, you can think about sort of how you would approach a patient rather than having formulas. And I don't know why. Just give me 1 second. I'm going to stop. Okay. Sorry. Okay. So if there's time, I'll go over an update on bloating since we're talking about hot topics and challenging cases. I would say of all the things I treat, bloating and abdominal distension is probably the most frustrating of them all. And, you know, with everything and I hope that you will also learn to tolerate ambiguity and have a framework for practicing physiologic-based medicine when evidence-based medicine is not available. So using the chat box, this is a question that I'm posing now as I present a case. The question is, what would you do and what else would you want to know about this patient I'm about to present? Please type your questions or answers or questions or anything you want to know in the chat box to try to make this as interactive as possible. So this is a typical day for me. Here's a 24-year-old patient who has symptoms of nausea, vomiting, postprandial abdominal pain, bloating, and constipation. She can't eat because of these symptoms, so she's on a very limited diet and losing weight. She's had symptoms for more than 5 years, but it's increased over the past 2 years after she suffered a flu-like illness, which she did recover from, but her GI symptoms never improved. Oh, I'm not sure what's going on with those marks. So her past medical history includes asthma, food allergies, migraines, Ehlers-Danlos syndrome, POTS, and a hip dislocation. She doesn't smoke, doesn't drink. She uses recreational marijuana occasionally. She's a former ballet dancer. Family history is only significant for migraines. So what else do you want to know about this patient? Okay, let me see where I can move my chat box here. Okay. So how I would approach, so I see here, any prodrome to the attacks, any prior surgery. So no prior surgery. So if I left anything out in the past medical history or past surgical history, it means that it has not existed. And so the way I look at patients like this who have had chronic symptoms, and I didn't go over the prior evaluations, but if I told you that EGD, colonoscopy, abdominal ultrasound, CT, abdomen, and pelvis were all negative, that would be part of the type of patients that I would see. But whenever I see patients who have chronic symptoms with multiple things going on, what I always do is start by eliciting their goals and their priorities. So start with the goals and priorities first before delving into the symptoms. And then the reason I review their comorbidities, and I'll go over this in detail, is to determine which conditions may be associated with GI disorders. So, and again, I'll go over some of these associations where chronic somatic or non-GI conditions are associated with higher prevalence of GI motility or functional GI disorders. And then I try to characterize the symptoms and the timeline. So was this acute onset? So it makes you think of like post-infectious gastroparesis, post-infectious functional dyspepsia, post-infectious IBS. So there's kind of post-infectious causes of GI motility disorders. Assess for alarm features, so weight loss, bleeding. So to kind of, as you're going through these questions, are you thinking about structural abnormalities versus functional? And when I say functional, I don't like to think of the term functional as sort of functional, kind of psychosomatic, but functional it truly is as in the function of the gut. So the muscle and nerves of the gut function. Are the symptoms triggered by eating, or is it more positional? So when it's positional, you may think of either musculoskeletal or more centrally mediated process. So as you know, pain signals, or whether it's pain from the foot, pain from the gut, or nausea, all these symptoms are processed in the brain. So the signal may start in the periphery, but it's processed in the brain. In patients with chronic pain conditions, you can get something called central sensitization, where the symptoms are more centrally mediated. And we see this in chemotherapy-induced nausea and vomiting, right? So someone who has acute severe nausea and vomiting with chemotherapy, the next time they go into the oncology office, even before receiving any chemotherapy, they're already feeling nauseous or sick. So these are central mechanisms. Again, meal-related or movement, to think of visceral versus myofascial. And then the overlapping disorders. So if they have numbness or tingling, think of like small fiber neuropathy or sensory neuropathy. If they have rashes or hives, you can think of mast cell activation disorder, eosinophilic esophagitis, eosinophilic gastritis, migraines. So, and again, I'll go over this in more detail, but migraines are associated with functional GI and motility disorders, but also medications used to treat migraines can also affect GI motility. For nausea and vomiting, if they have a positional component, you can think of the central, whether it's postural orthostatic tachycardia syndrome, or they can have a spontaneous CSF leak, which you can see in patients with EDS. If they have urinary symptoms like urinary retention, because of the pelvic floor muscles for the anal rectum share the same musculature as the bladder, then you can think of dysenergic defecation or obstructive defecation in patients with constipation. So these are kind of the things that I look for when I'm talking to patients in terms of assessing their histories. Oftentimes this history is there and they volunteer it. Other times I'm asking to elicit these questions. Physical exam, I'm looking at their posture and examining their spine, especially when someone's complaining of bloating or pain with movement. So if you look at the diagram of the woman who's standing straight with good posture, you see her abdomen is flat, but when she's hunched over, you can see the abdomen distend. In patients with severe kyphoscoliosis, essentially it shrinks their abdomen so that the visceral compartment or components then distend outward. So you can treat them with, SIBO, treat their SIBO all you want, or decrease their gas all you want, but it's really more mechanical. And then look for things like, rectus diastases. So look for separation in the abdominal wall that can lead to the bloating or distension. For abdominal pain, I always look for potential myofascial pain, so elicit a Carnett sign. And for those of you who have not done this, what you do is you palpate the abdomen when they're resting, and then elicit for abdominal pain. Have them either do like a crunch or lift their legs up, so where they're contracting their abdominal wall muscles, and repalpate. If the pain is more severe, then that's a positive Carnett sign, which makes you think of myofascial pain. I also I test their cutaneous sensation. The most sensitive is with ice, but you can do it with like light touch. And you can see here in the lower image there, the thoracic innervation of the abdominal wall muscle. So you can get abdominal cutaneous nerve entrapment. And generally, to elicit that, you can try to palpate the flank and see if it causes pain to radiate to the abdomen. But when you test the sensation, you'll see altered sensation. So if you test the right side and the left side, you may find that there may be hyper or hypoalgesia on the affected side. And then the rectal exam is not just looking for a mass or checking the hemocold. You'd want to do what I call a dynamic rectal exam. Ask them to bear down, squeeze. You want to feel the puborectalis relaxing, and then there should be some descent. So the perineum should descend approximately 2 centimeters, but not below the ischial tuberosity. So if you see, if the perineum descends beyond the ischial tuberosity, that means the pelvic floor is way too relaxed, and you may be dealing with a rectocele or pelvic organ prolapse that's causing some of these symptoms. So when I do a physical exam, I'm very focused in terms of based on the symptoms and what I'm looking for. So what are this patient's relevant history? So for the comorbidities, the migraine, the atopic disorders, the EDS, and the POTS, and these are all relevant to her symptom presentation and how you would approach her potential workup. In terms of the timeline, the fact that things are worse after a flu-like illness makes you think of like a post-infectious cause. So whether this is post-infectious gastroparesis or post-infectious functional dyspepsia. There are patients, depending on the viral infection, especially like with EBV infections, you can also get a post-viral autonomic dysfunction or dysautonomia, post-viral chronic fatigue syndrome, which kind of opens up a different can of worms into different types, different things that can affect the GI tract. So just to kind of touch on the comorbid conditions, this is a study that I was involved in looking at the gastroparesis consortium data on patients with gastroparesis and then chronic nausea and vomiting, but normal gastric emptying. And when we looked at these comorbid conditions like migraines, endometriosis, fibromyalgia, chronic fatigue, and interstitial cystitis, whether they had delayed gastric emptying or normal gastric emptying, the prevalence of these chronic pain conditions were a lot higher than the population estimates. And what we found that those with migraines were more likely to have more severe abdominal pain than those without in the gastroparesis population. But you see here the prevalence of migraine headaches in our gastroparesis population is over 30%. And here is sort of the pathophysiology of so what we think of as the pathophysiology of migraines, where there's autonomic dysfunction, altered serotonergic signaling, pro-inflammatory mediators, changes in gut microbiome. When you put this together and you look at that, and then you read the potential pathophysiology of gastroparesis or disorders of brain-gut interaction, they're very similar. And when you look at the migraineurs, over 80% of patients with migraines will complain of some GI symptoms. So there is significant overlap there. In the bottom panel with this body map, what we looked at in the pain clinic is that, patients marked where they had pain, and we grouped patients by isolated abdominal pain, intermediate pain where they had abdominal pain plus 1 to 3 other sites, and then widespread pain where they had pain in more than 3 sites. And what we found was that patients with widespread pain were more likely to have severe GI symptoms, greater pain interference, more anxiety, depression, and anger. So just keep in mind that when you're seeing patients who have multiple overlapping pain comorbidities, that you want to treat them in a sort of multidisciplinary approach early on, because these patients are more challenging to treat. So what about inflammation and atopic disorders? And you see here that whether it's allergens or bacteria, it can lead to activation of mast cells, which then release pro-inflammatory cytokines or mediators and neurotransmitters, which can alter motility as well as sensation. And here you see a retrospective study where they looked at 30,000 plus charts in a primary care practice over 5 years. And they looked at IBS, functional dyspepsia, constipation, and kind of an overlap of these in patients with atopic conditions. So they looked at like eczema, asthma, allergic rhinitis, and what they found was that patients with any atopic condition, they're more likely to have any functional GI disorder compared to the healthy controls. And you can see here, this is their overlap here. So they looked at the overlap of functional GI disorders, atopic conditions, or and mood disorders. And there was about 3% where all 3 overlapped, but about 22% of patients had functional GI disorders and an atopic condition. So patients with allergies are more likely to have a functional GI disorder. And what's interesting when you talk to them, and you can see this, is that during allergy season, when their allergies are flaring, their GI symptoms are more likely to flare. And so that makes you start thinking about sort of mucosal inflammation, not necessarily eosinophilic gastritis to the level of eosinophilic gastritis or esophagitis, but this is a meta-analysis looking at gastric mast cells and eosinophils. So these are endoscopic mucosal biopsies. And essentially what they found was more so mast cells than eosinophils, but patients with functional dyspepsia had more mast cells and eosinophils than the non-dyspeptic controls who were getting the biopsies. Similarly, in IBS diarrhea, this was a study looking at, this population was more of a post-infectious IBS diarrhea, and they got mucosal biopsies of the jejunum. And again, they compared this to healthy controls and found that patients with IBS diarrhea had more mast cells than healthy controls. The challenge is when you're looking at mast cells is we don't really have great cutoffs for what's normal and abnormal. So, what's normal and abnormal, and then within the abnormal, when is it more the functional dyspepsia, IBS diarrhea versus talking about mast cell activation disorder or mastocytosis? So this is a spectrum, and we need data on where the appropriate cutoffs are. In this study, they found that majority of patients who were healthy and normal had less than 20 mast cells per high power field. And if you haven't read this paper in Nature that came out earlier this year, I highly recommend it. It's a really well done paper where they looked at how inflammation can affect essentially the mucosal immune system, where individuals lose tolerance to foods. So it started with an animal model, and then they moved to humans, but essentially they induced a post-infectious IBS in animals, and found that what it did was it led to mast cell degranulation and sensitization. And then even after the mucosa healed post-infection, then it induced sort of food-related abdominal pain or IBS symptoms. And these are the patients where they come to you and they say that they're allergic to everything. They don't have the traditional highs, but everything they eat, they become intolerant to. And the thought is that the inflammation leads to disruption of the mucosal immune tolerance to foods. And this may be the mechanism for postprandial abdominal pain. So I've made this argument that allergy or the immune system, the mucosal immune system may play a role in functional dyspepsia and IBS diarrhea. So can you treat these patients with antihistamines or mast cell stabilizers? And this was a study that was published last year where they took patients with IBS, and this is mostly a post-infectious IBS diarrhea group. They looked at symptoms as well as they looked at sensation using balloon distension on the anorectal manometry. And what they found was that ketotifen, which is a mast cell stabilizer, can decrease symptoms. So patients had over 76% of patients had a reduction of more than 50% in their IBS symptoms over 8 weeks of ketotifen. And then with the balloon distension, that they had a higher sensory threshold. So it helps with visceral sensation as well as IBS symptoms. So what this shows you is there's a potential role for antihistamines or mast cell stabilizers in this population. And this is from the pediatric population, and they've been using antihistamines for a long time. They're using ciprofloxacin, which is a first generation antihistamine and serotonin receptor antagonist. And this is a retrospective study in their patients with various functional and GI motility disorders, including functional abdominal pain, functional dyspepsia, cyclic vomiting syndrome, IBS, and 73% had complete resolution or improvement, remission of their symptoms on the ciprofloxacin. So I do use a lot of ciprofloxacin. The main side effect is sedation and weight gain. So if I have someone who has insomnia or they're underweight, I typically prescribe this at night. Because it's a serotonin receptor antagonist, you do have to be aware of interactions with other psychotropic medications. So if they're taking an SSRI for anxiety or depression and they're stable, starting ciprofloxacin may lower their serotonin levels and cause them to have increased symptoms. So what about hypermobile spectrum disorder or hypermobile EDS? When you talk to the people who specialize and do research in this area, there's nuances. So I tend to group everything as a hypermobile spectrum disorder or joint hypermobility. So they have some flavor of hypermobility. You can test for hypermobility very quickly in the office. It takes less than a minute. And you can do a Beighton score. And if they are over 50, sorry, my numbers are off. So if they have 5 or more joints affected, then it's considered hypermobility. And so you just have them I start with having them try to touch their thumb to the forearm. As you can see, I can't do that. Bend their pinky back. Again, I can't do that. And then straighten their elbow. And then for the ninth point, or number 1 here, you have them stand straight without bending their knee, touch the floor with their palm. So, you can yoga all you want, or you can do ballet all you want, but you can't make yourself be this hyperflexible. Now, these patients tend to have a lot of injuries, like joint dislocations, especially if they were former ballet dancers or gymnasts. So you may have to ask for historical hypermobility, because if they have had hip surgery or knee replacement, they will not, you won't be able to elicit the hypermobility there. So what are the clinical manifestations of EDS, and why it's important is because GI manifestations are common, and it runs the gamut. You would think that it would be, if you had EDS, then you are likely to have X, but you can have gastroparesis, functional dyspepsia, rapid gastric emptying, slow transit constipation, IBS-C, IBS-D, pelvic dyssynergia. So it's just sort of the whole gamut. And they tend to have a lot of joint spine issues, as well as more CNS manifestations. And among patients with EDS, depending on which studies you look at, up to 90% will have some type of GI symptoms. The most common symptoms tend to be more on the functional GI or DGBI spectrum of IBS, functional dyspepsia, and heartburn. And in the box to the right, you'll see this is a study done in the UK, but they went into a general GI practice. So not a Linda Nguyen tertiary care motility practice, but a general GI practice. And they just enrolled people who were waiting in the waiting room to see the gastroenterologist. And they had them do this joint hypermobility. And what they found was that a third of the patients coming into the general GI practice were newly diagnosed with hypermobility. And so these are patients who never knew that they had EDS, but when they were screened in the waiting room, they were found to be hypermobile. So the patients are there. If you've never seen a hypermobile patient, that means you haven't looked. And you know, I diagnose at least one new person per week. Patients who came in and were referred by the rheumatologist with known EDS, they were more likely to have severe GI symptoms and more likely to have functional GI disorders as opposed to any of the other diagnoses. They did tend to be younger women and higher. The COMPASS score is an autonomic score, and with overlapping fibromyalgia, chronic pain, and decreased quality of life. So POTS is the other condition. POTS and EDS oftentimes go together, but you can also see patients with POTS without EDS. The most common clinical features of POTS is postural dizziness and palpitations. But I often have patients who experience this as nausea. Like every time they get up, they feel nauseous, but their heart rate goes up to 120 or 140. What's really interesting is, or sometimes scary and alarming, is someone comes in with nausea, you schedule them for an endoscopy, and walking from, you know, the pre-op room to the procedure room, their heart rate goes up to 140, and that's all they did was, you know, walked 30 steps. You can diagnose it quickly in your office, and by doing orthostatic vital signs. So you do supine, then have them stand up, wait for a minute, and then recheck their heart rate. Repeat in 3 and 5 minutes. And what you're looking for is a sustained increase in heart rate that is more than 30 beats per minute, or their heart rate is more than 120 beats per minute. I usually stop after 5 minutes. Sometimes they will extend out for 10 minutes, and you'll just see this persistent tachycardia. And at times, the longer they stand, the more tachycardic they get. When someone is hypovolemic because of dehydration, you'll see a transient increase in the heart rate, but then it'll come back down after there's vasoconstriction. There are 3 types of POTS. There's the hyperadrenergic POT, hypovolemic POTS, and neuropathic POTS. They're mostly, just so you know, that they're treated differently. So if they have hyperadrenergic POTS, then oftentimes using a neuromodulator to decrease the sympathetic activity will help with their symptoms. But I'm not expecting you to be POTS specialists after this, but just know that there are different types of POTS. Patients with POTS Frequently will present with nausea, vomiting, and abdominal pain as their most common presenting symptom, and this is present in almost 70%. Patients with POTS who also have small fiber neuropathy are more likely to have more severe symptoms. And here is a table of just the different studies showing the symptoms, the population, and sort of what their physiologic abnormalities are. And as you can see, you see a combination of rapid and delayed gastric emptying in this population. And then the final risk factor or patient history is sort of the post-inflammatory, post-infectious GI dysfunction. I'm using IBS here, but you can also, you see similar data with gastroparesis and functional dyspepsia. In patients who have an acute gastroenteritis, they're at 7 times increased risk of developing post-infectious IBS. They can recover, but the recovery can be years down the road. For those of you who are interested in, in IBD, patients with Crohn's and ulcerative colitis can also present with post-inflammatory IBS. So these are patients who have inflammatory bowel disease and they're in endoscopic remission, yet they still are symptomatic. And these are patients that you don't want to change their immunotherapy. You want to treat the underlying IBS, and then also with diverticulitis. And these are the types of patients that you see where they come into the ER, they have acute diverticulitis, they continue to have pain, but every subsequent CT scan they've had after that is negative. These patients are getting way too much radiation, but not being treated for the post-diverticulitis IBS. Okay, so I'm going to pause there for a second if there are any. I see any questions. So in terms of asking a pathologist to stain for the mast cells, so you can ask for tryptase stains and CD117 stains for mast cells. The challenge is getting the pathologist to quantify them. They'll stain them, but they won't quantify them. And that's because there's no standardized way of quantifying them and getting an appropriate cutoff. So I think where we need to go next is to have to work with the pathologist to establish these protocols and these cutoffs. So moving on to sort of from the patient in terms of what is a relevant medical history and what you think about, just stepping back to what do you think about or how do you approach anyone with unexplained upper GI symptoms. So you start with uninvestigated dyspeptic patient. If they don't have alarm features and they're under the age of 60, you can test for H. pylori and treat. If they're positive, you can treat the H. pylori, confirm eradication. If the symptoms go away, it was the H. pylori that caused their symptoms. If their symptoms persist, then the H. pylori may have caused inflammation, and then they've gone on to develop a post-inflammatory dyspepsia, or the H. pylori was never really the cause of their symptoms. Or if the H. pylori is negative, then you think about the diagnosis of functional dyspepsia. When you look at the guidelines of, uninvestigated dyspepsia and the diagnosis of functional dyspepsia, you see here in the absence of alarm features in individuals under the age of 60, endoscopy doesn't fit in here anywhere. But the reality of it is that if someone has persistent symptoms that doesn't resolve, even in the absence of alarm features, I still would do an endoscopy more for reassurance of the patients. And so that you can focus on treating the symptoms rather than having them always question whether or not there's an ulcer or a cancer that's causing their symptoms. You see here that I use a question mark on the cutoff age for alarm symptoms of being 40 for Asians. And if you look, there's an Asian consensus document that came out a couple of years back of similar thing, similar guidelines for uninvestigated dyspepsia, but because in Asia, the risk for gastric cancer is higher, they lowered the age for alarm symptoms. Now, do those risks translate when you move, when, you know, Asians immigrate to the US, or if you're second, third generation Asians? We don't know that. So that's why the question mark. And so if they do have alarm features or they're older, then you want to rule out a structural abnormality. And the main thing here is don't be afraid to make the diagnosis of functional dyspepsia. I think what's frustrating for patients is that they have these symptoms and they undergo a lot of testing, endoscopy, ultrasound, CT scans, and everything is normal, but they're still symptomatic. And if you say, well, you know, your endoscopy is good, your CT scan's fine, and you don't take it the next step, then the patient's left with, okay, well, everything is fine, but I'm not. So are you missing something? So don't be afraid to make that diagnosis of functional dyspepsia. And part of making that diagnosis is understanding sort of the physiology of the stomach and what it does, and to explain it to patients why they feel the way they do. The stomach is complex. The fundus functions in liquid emptying and accommodation. So for those of you who are eating, if you eat, you know, as you eat, the fundus is accommodating to allow you to eat whatever meal you have there without excessive fullness and early satiety. This is coordinated by the pacemaker. You've got the antrum, which grinds and mixes everything. Then the pylorus, which contracts to allow for that mixing and grinding. Then you have the antroduodenal coordination. So an abnormality in any of these areas can lead to chronic upper GI symptoms. And so then what's the difference between functional dyspepsia and gastroparesis? And this is in a talk by itself, but mostly functional dyspepsia is defined based on symptoms. So it's, you know, bothersome, postprandial fullness, early satiety, epigastric pain. There's two subtypes. There's the postprandial distress, which is the meal-related, then the epigastric pain syndrome, which may or may not be meal-related. Gastroparesis is defined by the physiology. So it's defined by the abnormal gastric emptying in the absence of mechanical obstruction. But yet when you look at the symptoms of gastroparesis, they're exactly those of functional dyspepsia. And when we looked at our population of patients with functional dyspepsia and applied the Rome criteria for functional dyspepsia, over 80% of these patients met Rome criteria for functional dyspepsia, with majority being postprandial distress. So that raises the question of whether or not functional dyspepsia and idiopathic gastroparesis are the same or different. And I'm not going to go over this in detail, but this is sort of comparing side by side the pathophysiology, symptoms, duration, diagnostic criteria, and gastric emptying findings between those two. And again, there's some differences, but a lot of overlap that you see here. And so the way I think about functional dyspepsia and idiopathic gastroparesis is it's a spectrum and distinct conditions. So patients with functional dyspepsia, normal gastric emptying with EPS symptoms, those are clearly a subset of functional dyspepsia. Idiopathic gastroparesis, where they have postprandial nausea and vomiting with or without abdominal pain, they have severely delayed gastric emptying. Those patients fall into the idiopathic gastroparesis. Then you have in the middle, where they have postprandial symptoms and their gastric emptying may be mildly delayed. Do they function like idiopathic gastroparesis or functional dyspepsia? Right now, especially with functional dyspepsia, these are symptom-based diagnoses, which are nonspecific. And I'm hoping that in the future, we'll be able to have biomarkers which are needed to help guide therapy and diagnosis. So my approach, I'm going to go through this really quickly so there's time for questions and answers. So if I do the endoscopy, there's no structural abnormalities. I do evaluate for gastric emptying. There's 2 tests that you can use: the gastric emptying scintigraphy, which is the nuclear medicine test; wireless capsule motility, which is a capsule that measures pressure, temperature, and pH. The wireless capsule motility can measure small bowel and colonic transit, while the scintigraphy only measures the stomach gastric emptying. Treat the predominant symptom and comorbidities. So if you encounter a patient with severe psychiatric or somatic comorbidities, you want to have a multidisciplinary approach and start that early. For patients with mild symptoms, oftentimes they just want to understand why they feel that way. They make a diagnosis, reassure them, and then they're done. They can tolerate their symptoms. I've seen so many patients who have like 1 or 2 out of 10 pain, and they've seen 10 different doctors. And really, it's not that they want their pain treated, they just want to understand why they have their symptoms. And the reason I keep harping on looking for, extraintestinal and psychiatric comorbidities is that patients with GI disorders who have extraintestinal comorbidities like chronic pelvic pain, interstitial cystitis, fibromyalgia, migraines, they tend to have more severe GI symptoms and poor quality of life. Same thing with, if they have anxiety, depression, somatization, PTSD. So the treatment of gastroparesis and functional dyspepsia, again, I'm not going to go into these in detail, but they look very, very similar there. And I sort of outline these as, if you have someone with idiopathic gastroparesis, but the postprandial, I kind of put them into the postprandial distress subtype. The patients with EPS do respond to PPI therapy. Those with postprandial distress really don't respond to PPIs. Similarly to TCAs. So the EPS patients respond to TCAs. They don't respond. The patients with PDS or idiopathic gastroparesis do not respond to the PDS. So there's differential response to therapies, which is the importance of trying to better classify the patients. And then with the pro-motility agent, especially if they have extra gastric dysmotility, and this is a wireless capsule motility study where we found that over 50% of patients coming for upper GI symptoms had significant lower GI dysmotility, whether it's small bowel or colon. What they found is another study that used prucalopride or Motegrity, which is currently FDA approved for constipation. They found that starting prucalopride does help with gastroparesis symptoms. And here's the data on the symptoms as well as the emptying. So you can't prescribe right now prucalopride for gastroparesis, but you can prescribe it for constipation. So if you have a patient with gastroparesis and constipation, I would prescribe the prucalopride. So for the chat box, so what next? But I'm going to go through this very quickly. So the patient's abdominal pain was better on duloxetine or Cymbalta, but the nausea, vomiting, and constipation was worse. We ended up doing a wireless capsule motility study, and the results are there. They were started on some new migraine. They couldn't remember the name for severe migraines. And it turns out that the occasional marijuana use that was reported earlier was more recreational, but they've been using marijuana 1 to 3 times per day for the past 2 years for migraines, nausea, vomiting, and sleep. So I'm going to just move on to sort of the what next part of things is that, for someone who has severe pain, think about neuromodulators. And if you're not comfortable using neuromodulators, choose a few. Start with one that you're comfortable with. Know how to dose it, the titration interactions, and get comfortable with it. And then once you're comfortable with that, choose another one. If you're worried about like, well, I don't understand the side effects, We prescribe a lot of other medications with a much riskier side effect profile. So the neuromodulators should be super easy to learn. And when you use neuromodulators, you want to think about sort of the side effect profile, what other things you might be treating, and then oftentimes you need to use augmentation therapy. So you don't want to stop with one neuromodulator. You may get partial benefit, but you may need to add a second or even a third. So here's a summary, and I'll send this out of the different drug classes and the potential effects on the gut, the impact on symptoms, and the side effects. And again, when you think choosing the neuromodulator, there's no one like best neuromodulator. It's really looking at what the effects on the GI, what symptoms you're trying to choose, and then leveraging some of the side effects. So for patients who have disordered sleep, I'll use sedating neuromodulators to help with their sleep. And then when you think about, pain, it's not just the visceral aspect of it. There is the visceral peripheral sensitization, but then there's the guarding reflex. So that's where you get the abdominal component, the myofascial abdominal component. If they have kind of joint pains, you can also get sort of guarding reflex. And if they have kind of multiple pain areas, you get this central sensitization where there's an amplification of pain in the spinal cord. And then the descending inhibition is where the brain is supposed to turn off pain signals. And in the absence of that descending inhibition, the pain just continues to cycle. So our pain specialists think about sort of the pain cycle this way, and there are different treatments that can be applied to the different areas of the pain cycle. So you can augment or overlap therapies so that you're addressing the entire cycle of pain. And then I'm going to finish up here with a reminder of chronic abdominal wall pain, which is prevalent in up to 30% of patients coming into a GI clinic for abdominal pain. And typically this is pain that's unrelated to food. It's worse with movement. You get a positive Carnett sign, and it can be due to an anterior cutaneous nerve entrapment symptom, intercostal neuralgia as the nerve comes through the intercostal muscles. It can be radicular from the thoracic spine. So always for abdominal wall pain. So in the end, so what's this patient's diagnosis? They have gastroparesis and slow transit constipation. What medication was it that they were using for migraines? It's Evidencebased or Aimovig, which is the CGRP receptor, or CGRP blockers have been a blockbuster for migraine therapy, but they are associated with alterations in GI motility. With Aimovig, constipation is the most common side effect. On exam, this individual did have the Carnett sign and was diagnosed with anterior cutaneous entrapment syndrome. So what did I do with this person? I started prucalopride for the constipation and the gastroparesis. I augmented duloxetine with gabapentin to help with the migraines. I asked them to talk to their neurologist about switching Evidencebased to potentially a different therapy, so a ligand blocker, and then refer them to the pain clinic for transversus abdominis or TAP block for the anterior cutaneous nerve entrapment syndrome. So in summary, a whirlwind tour, covered a lot of things. Just a reminder that overlapping somatic conditions are common and negatively impact symptoms and quality of life. Understanding the pathophysiology of the overlapping conditions may provide further insight. Right now, treatment is predominantly aimed at symptom control, and I incorporate shared decision-making with every patient. So, I tell them what I think that they would benefit from, and then we negotiate from there. And that includes, complementary or alternative therapies, behavioral therapies, as well as medications. And in the absence of GI-specific evidence-based therapies, try to adopt a practice of physiology-based medicine. Evidence isn't there. For gastroparesis, the only FDA-approved therapy is metoclopramide for diabetic gastroparesis. So if I was going based off of evidence-based therapy, I would have nothing. I would have 0 patients and a very short career as a gastroparesis specialist. Get comfortable with neuromodulators. If you don't have a favorite, find one, get multiple. And what we do need are GI-specific studies to determine the best augmentation strategy. Right now, it's really based on kind of side effect profile and what other medications the patients are on. So with that, I'm going to end, and I did not have time to cover bloating and distension. Happy to come back at another time to discuss this and send out my slides. And I will stick around for other questions if you have any. Oh wait, I have to shout out. Hi, Marty. Marty Lieberman was my attending when I was a fellow, so I have not seen him in I don't know how many years. So good to see you, Marty. So any questions?
I had a question, maybe if people want to enter into the chat. But I was curious, I was wondering if you were going to bring this up when you presented that history of the patient with in her marijuana use. And just wanted to get a sense of, I find that sometimes we always kind of wonder if that may be a contributor to their symptoms, or if they have like some kind of like a cyclic flash of vomiting, and how do you kind of address that if you're trying to see if that's something correlated or not?
Yeah, so I had a marijuana slide deck, but as you can see, I cut out a lot of my slides already. So the role of marijuana in GI symptoms is complex, because if you look at patients, whether they have gastroparesis, functional dyspepsia, or inflammatory bowel disease, they all will respond in survey studies that they found their marijuana to be beneficial in relieving their symptoms. But then we're left with the cannabinoid hyperemesis or CHS. And then the other part is that THC does slow GI motility. So THC and THC by itself, but also the cannabinoid agonist can slow down and affect GI motility. The diagnosis of CHS really requires a history that patients started the marijuana before the onset of symptoms. And when you look at CHS patients, typically they've been using marijuana more than a year, and they have to be heavy users. And what is considered heavy use is at least 4 times a week, every day, 4 times a week for over a year. And then their symptoms resolve with discontinuation of the marijuana. THC is lipophilic, so they have to stop it for generally 3 to 6 months, or a minimum of 3 cycles of their symptoms. So if they have kind of like cyclic vomiting syndrome type symptoms, and their symptoms are, once every 2 months, then you need 6 months. If their flares are once every 4 months, then you need to wait a year to see that. I think we tend to overdiagnose CHS, or we try to blame too much on marijuana. So I think you have to, what I generally counsel patients on with marijuana is go to a good dispensary and try to get more CBD, less THC. For some reason, the inhaled cannabis tends to be associated with more side effects. So using tinctures, so kind of under the sublingual tinctures or edible, although the edible has a slower absorption.
Great, thank you so much. It looks like some other questions from our chat box. So how about the use of TENS units? How effective is that for functional dyspepsia?
So TENS units, if you're just putting it to the abdominal wall, it doesn't help necessarily with functional dyspepsia, but it helps with the abdominal wall pain or the myofascial component. So if you have if you elicit tenderness of the rectus muscles, using a TENS unit to the abdominal wall can help. I've got a study going on looking at vagal nerve stimulation and functional dyspepsia, so we'll see about that.
Great. And also, sorry, going back to the question or when you're talking about CHS, any thoughts of Haldol use, I guess, or any anecdotal reports of that?
Yeah, so Haldol can help for any type of nausea and vomiting, but it has such significant side effects with it. I tend to start with promethazine or compazine plus Benadryl. There was a nice study that was done in the ER randomizing patients with migraines to compazine plus Benadryl versus Dilaudid. And the compazine plus Benadryl group actually had a greater response and shorter duration in the ED than the Dilaudid group. So kind of borrowing from the migraine group, I tend to use either compazine or promethazine plus the Benadryl. The Benadryl is to kind of decrease the tardive dyskinesia type side effects, but also antihistamines help with nausea. Because the CHS is thought to be due to the TRPV1 receptor, that using capsaicin. So capsaicin is a TRPV1 agonist, and then it downregulates the receptor. I actually will have patients use capsaicin cream, ointment, or a patch when they feel sort of their aura, and then just kind of put it on their abdomen.
Oh, great. I don't know if anybody else has any other last questions, but otherwise wanted to really thank Dr. Nguyen again for spending the time and giving us this wonderful talk, super interesting, and staying late to answer some of our extra questions as well.
Yeah, not a problem at all. You're very, very welcome. Feel free to, I don't know if you guys have my email, but feel free to email me if you have any questions about that. Sorry I didn't get a chance to go over the bloating slides. But yeah, so everything it was a lot that we covered today, but everything that's covered is like one whole talk in of itself. Hopefully, as you guys go through your fellowship, that you can look at each of these conditions not as sort of too complex to handle, but if you kind of break it down, it makes it a lot easier.
Great. We'll just have to have you come back hopefully and give us another talk very soon to cover the rest of everything. All right. Great. Thank you so much again, and thank you all for sticking around for this talk.
Bye, everyone.